Hello, everyone, and welcome to the next installment of Risfeld Neurology Education, a not for profit, completely free, and easily accessible project exploring all aspects of clinical neurology. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. We've got a good episode for you today, and it's focusing on epilepsy definition and classification. And before we get into it, a legal disclaimer. The content in this episode and in the Risfeld Neurology Education Project as a whole is for educational purposes only. So let's dive right into it. Oh, and I should say before we start that you should listen to the previous episode on the definition and classification of seizures if you haven't already done so, because that's basically prerequisite knowledge to be able to understand this episode. So, what is epilepsy? Well, it's a condition with at least one unprovoked seizure and a predisposition to future unprovoked seizures. And that can be established in one of three ways. Firstly, someone who in their life has had 2 or more unprovoked seizures, and importantly, they need to have been more than 24 hours apart. So what that means is if someone in their life has had 2 unprovoked seizures, but they were within 24 hours, that's counted as the same seizure episode, because we know from epidemiological studies that if 2 seizures happen so close together within 24 hours, that's in the context of whatever's happening at the time, and it doesn't on its own indicate an increased risk of having a second unprovoked seizure in the future, which is significantly increased. So the 2 unprovoked seizures need to be more than 24 hours apart to be counted as separate episodes. The second way that you can meet the definition is if you've had 1 previous unprovoked seizure, but in addition to that, you have a greater than or equal to 60% chance of having a second unprovoked seizures in the next 10 years. And why was that number chosen? That number was chosen, again, based on epidemiological studies showing that if someone has a diagnosis of epilepsy based on the first criterion, so 2 unprovoked seizures, then their chance of having a third unprovoked seizure is greater than or equal to 60%. So if you can make the diagnosis of epilepsy earlier after 1 previous unprovoked seizure, but you still know that the patient has 60% or higher chance of having another seizure, then that's essentially the same thing in terms of the risk of having another seizure. So you can diagnose epilepsy at that point at an earlier time point. So that then asks the question, well, how do you establish that the patient has this increased chance of having a seizure in the next 10 years? And pragmatically, that's done in one of 2 ways. Firstly, if they have a structural brain abnormality on neuroimaging, so a CT or more commonly an MRI of the brain, that is thought to be significantly epileptogenic. So basically, that means it needs to have cortical involvement and it needs to be deemed clinically significant in terms of the first seizure that they had. So if someone has, say, a focal impaired consciousness seizure, which seems to lateralize to the left cerebral hemisphere with some motor features, and an MRI is performed and it shows that there is a left-sided cortically based lesion, such as a focal cortical dysplasia, then that would be considered an epileptogenic or a potentially epileptogenic lesion, and that would meet that criteria. Conversely, if the same patient had an MRI and it showed some brain abnormality that wasn't clinically significant, so maybe there was a small susceptibility weighted imaging abnormality indicative of a microhemorrhage in the cerebellum, or maybe there's a pineal gland cyst or something just not related at all, then that's not abnormal or epileptogenic enough to satisfy that criterion. The second way that you can meet the 60% rule is to have an abnormal and epileptiform interictal EEG. So what does that mean? So this isn't an EEG episode. We'll do a dedicated EEG series later on. But in terms of epileptiform findings on EEG, they can be ictal, so at the time of a seizure, or they can be interictal, so in between seizures. But there can also be abnormalities on an EEG which are not epileptiform abnormalities, but abnormalities consistent with some other pathologies such as a delirium or an encephalopathy or a structural lesion such as a stroke or a tumor. And they classically manifest with slowing, but without epileptiform features like rhythmic slowing in particular patterns, which we see in epilepsy sometimes, or even more obviously than that, spike and slow wave discharges or sharp wave and slow wave discharges. On a routine EEG in this context, after a first seizure, it's really unlikely that you're going to catch an ictal event on an EEG, especially given that a routine EEG only goes for 20 minutes or 30 minutes sometimes. So we're really looking for interictal epileptiform EEG changes. And that's why we like to do an EEG after a patient has a first seizure, because we may be able to actually make a diagnosis of epilepsy after the first seizure and start that patient on treatment. So what are some things to be aware of here? The first thing is that EEG can be misleading if it's not interpreted correctly, and if the reporter doesn't report the EEG correctly as well. So there can be lots of normal variants, so it's important that they're not overcalled, leading to overdiagnosis. And on the other side of the coin, it's important not to undercall, obviously, abnormal findings as well. The other thing is that the way that you do the EEG matters. So the timing matters. The sooner that you can do it, the higher the chance is that you'll capture the interictal epileptiform discharges if they are present after the first seizure. So if you can do it within a day or two, that's better than waiting a week or 2 weeks or a month. But ultimately, you just have to take what you can get in the local district that you're working in with the resources that you have available to you. But the sooner the better. Also, sleep-deprived EEGs are generally more sensitive than a routine EEG, because with sleep deprivation, you're more likely to capture sleep, and even just the fact that the patient's in a sleep-deprived state, even if they're awake or drowsy, is thought to possibly also bring on epileptiform discharges. In practice, what we normally do, and what I think most centers would normally do, would be to start with a routine EEG, and if that's normal, then to progress onto a sleep-deprived EEG. There is also the option of doing prolonged EEG recording, so doing an extended EEG for an hour or 3 hours or 6 hours, or doing a proper prolonged ambulatory EEG for 1 day, 2 days, sometimes longer than that, looking for interictal epileptiform discharges. That's obviously much more expensive, much more time and resource consuming, and is of limited availability. But that is another option that you have available to you if you're really hunting for interictal EEG changes to try and catch that diagnosis of epilepsy and get the patient on treatment. Now, the third way and the final way that you can meet the diagnosis of epilepsy is if you have one previous unprovoked seizure, but you also, in addition to that, meet the diagnostic criteria for a specific epilepsy syndrome, which is what we're going to be talking about shortly. Although in clinical practice, really, to diagnose a specific epilepsy syndrome, that's going to be dependent on the imaging and the EEG anyway, which we've already talked about, and or dependent on genetic testing. So if you had a patient who had a seizure in the context of, say, a family history of a known familial epilepsy syndrome, and you were to do genetic testing and the patient had the same genetic deficit, then you could make a diagnosis in some instances of a specific epilepsy syndrome, and therefore a diagnosis of epilepsy after even just the first seizure. So, is there any grey area in all of this? As you may have guessed, yes, there sometimes is some grey area. So firstly, there can be grey area in what's considered provoked. And I did discuss this in the previous episode on the definition and the classification of seizures, but I'd like to revisit it quickly. So firstly, an acute symptomatic seizure or a provoked seizure happens within, by definition, 7 days of the acute insult. But of course, using the number 7 is a completely arbitrary cutoff. Is there really a clinically significant difference between someone who had a focal impaired or preserved consciousness seizure 6 days after a hemorrhagic stroke as opposed to 8 days after a hemorrhagic stroke? Probably not. Also, The severity of the provoking factor could vary, and so that could ask the question, well, how severe is severe enough? How severe isn't severe enough? So if someone had a seizure in the context of a sodium of 100 millimoles per liter, is that low enough? What about if they had a sodium of 120 millimoles a liter? Is that low enough? Or would you consider that maybe not to be low enough to have provoked a seizure? The next point is that even if a patient has a provoked or an acute symptomatic seizure, we know that those patients are actually at an increased risk of having unprovoked seizures in the future, as well as just future provoked seizures. And it does depend in some part, at least, to what the provoking factor is and whether that provoking factor is going to be sustained or not. And that leads me to the next point, which is what if the acute symptomatic seizure was in the context of an acute illness, but that acute illness is going to persist in some way? So, what if it's an acute trauma less than 7 days ago, leading to a seizure, but there's resultant permanent encephalomalacia? Is that then a post-traumatic epilepsy, or is it still just an acute symptomatic seizure? Or what about in the context of an acute ischemic or hemorrhagic stroke less than 7 days, but with resultant permanent encephalomalacia? Is that just an acute symptomatic seizure, or is it epilepsy, post-stroke epilepsy, because there's then abnormal brain tissue on imaging? These are really difficult cases, but generally speaking, if it's an acute symptomatic seizure less than 7 days from an ischemic or a hemorrhagic stroke or from trauma, even though there's underlying encephalomalacia, we'd still call that an acute symptomatic seizure as opposed to epilepsy at that point until the second seizure happens. However, many clinicians may, perhaps rightly, choose to treat with antiseizure medications at least for a period of time, and then make a somewhat challenging decision as to whether to continue those antiseizure medications or whether to stop them at some point down the track. Tumor-related epilepsy or tumor-related seizures are even more tricky. So suppose someone presents with a seizure, they get a brain scan, and it demonstrates that there's an underlying brain tumor, perhaps a glioma, a primary brain malignancy, which is the cause of the seizure. So the tumor, by definition, was diagnosed in the last 7 days. Presumably, it's been there for longer than that. Do you call that an acute symptomatic seizure, or is that epilepsy? Or what if you deal with the tumor? What if the patient has tumor resective surgery, chemotherapy, other systemic therapies such as immunotherapy or hormonal therapy? What if they have radiotherapy? What if they're cured of their cancer? Was it just an acute symptomatic seizure, or do they have epilepsy, especially if there's permanent encephalomalacia following all the surgery and chemotherapy and radiotherapy? That's a tricky one. It somewhat, for pragmatic purposes, would fall in the same category of the last two examples. So most epileptologists and physicians would treat with antiseizure medications initially, see how the patient goes, and then make a tricky decision on a case-by-case basis down the track as to weighing up the pros and cons of continued treatment to decide with the patient whether to continue treatment or not. What are some other grey areas? What if a patient had a first unprovoked seizure consisting of, for example, a generalized tonic-clonic seizure when they were 8 years of age, and then they had their second unprovoked seizure, which was a focal to bilateral tonic-clonic seizure with no demonstrable underlying cause when they were 50 years of age? Realistically, many epileptologists would consider these two episodes just far too distant and different to say that this alone constitutes a diagnosis of epilepsy. They were separated by 42 years and they were completely different types of seizures. That's just two worlds apart. It's hard to say that that patient really has epilepsy, even though technically they have had two unprovoked seizures. And thirdly, this one's a little bit philosophical more than anything, but I'd like to mention it. What about if a patient has typical EEG findings of a particular epilepsy syndrome, A good example of which would be JME, juvenile myoclonic epilepsy. So what if they have fast generalized spike and wave? So that means 4 to 5 or 4 to 6 hertz generalized spike and wave discharges. And suppose that that patient also had a family history of juvenile myoclonic epilepsy, but maybe this patient hasn't even had one seizure. Maybe they've never had a seizure, and that's because they were incidentally already put on anti-seizure medication for some other indication. So what if that patient had been put on valproate because they also have bipolar affective disorder or migraine? And this was an example that was put to me by one of my senior epilepsy colleagues, which I hadn't thought about. But I think he makes a really good point. So if you stop the valproate in that patient, then they'd be at very high risk of having a seizure in the context of their juvenile myoclonic epilepsy. So is it really true that that patient doesn't have epilepsy just because they've never had a seizure, but that's because they happen to be on treatment anyway? Despite seeming like a bit of a long bow and a little bit difficult to believe, I have seen the opposite be true twice actually in the last 4 months. So in our comprehensive epilepsy service in our seizure investigation unit, I've seen 2 patients who came in with a diagnosis of epilepsy, and they were being treated with a lamotrigine, and we deliberately weaned their lamotrigine to try and precipitate seizures, which is what we do. And both of those patients became hypomanic or manic, and we wondered whether this patient actually had previously undiagnosed bipolar affective disorder, which was being unmasked by the weaning of the lamotrigine, which is a mood stabilizing medication often used for bipolar affective disorder, but it's also, of course, an anti-seizure medication used for epilepsy. So it seems that in the other direction, there have been examples of patients who had another disorder that was coincidentally being treated by a medication for some other indication. So it's not such an absurd suggestion that it could happen in the other direction as well. So I've just spoken about how to diagnose epilepsy, but why is diagnosing epilepsy important? Well, generally speaking, an epilepsy diagnosis warrants anti-seizure medication treatment, whereas a first unprovoked seizure, which does not otherwise meet the diagnostic criteria for epilepsy, or provoked seizures or acute symptomatic seizures, whether they are single or recurrent, generally speaking, although with exceptions, do not usually warrant treatment with anti-seizure medications. However, there are, as I said, important exceptions on a case-by-case basis. For example, if a patient has recurrent, provoked, or acute symptomatic seizures where the provoking factor still remains into the future. So the classic example would be a patient who has recurrent alcohol withdrawal seizures, but there have been unsuccessful, perhaps repeated unsuccessful attempts at successfully achieving abstinence from alcohol. So the underlying problem has not been addressed. The patient's continuing to drink, continuing to have alcohol withdrawal, continuing to have seizures. Then using an anti-seizure medication as a harm minimization strategy, I would argue is completely reasonable in this circumstance, and many of my colleagues would treat with anti-seizure medications in this circumstance as well. Conversely, there may be some instances in which a patient who does meet the diagnostic criteria for some epilepsy syndromes or some forms of epilepsy may not require anti-seizure medication. And the main example here would be some pediatric epilepsy syndromes, which are relatively benign. They've recently renamed all of the pediatric epilepsy syndromes in 2022 and taken out the words benign to reflect the growing appreciation that these formerly thought to be benign epilepsy syndromes are not actually completely benign, but relatively speaking, reasonably benign epilepsy syndromes. It may be that the harms of anti-seizure medications actually outweigh the benefits. And so usually it's then a case-to-case discussion with the family as to whether to start treatment or not. And the classic example of that would be what is now known as SELECS, or self-limited epilepsy with centrotemporal spikes, formerly known as benign Rolandic epilepsy, or BRE, and we'll discuss that shortly. Why else is diagnosing epilepsy important? Well, it often has important social implications. So, for instance, it's important regarding driving and driving restrictions in many jurisdictions, including in Australia, and we'll have a separate episode on that at another time. Also, if you are able to diagnose the underlying epilepsy syndrome, then in some instances, not all instances, but some instances, that will then guide further treatment. So, what are the actual steps that you need to go through in order to make a correct diagnosis of epilepsy in a patient? Well, there are 6 things that you need to do. The first thing is that you need to confirm that the episode is actually a seizure and not a seizure mimic. And this is often overlooked and not done well, and it's going to be the topic of our next episode. The second thing that you need to do is to confirm that the seizure is unprovoked as opposed to provoked, and we've already spoken about that. The third thing is to confirm that the unprovoked seizure meets the diagnosis of epilepsy, and that's what we've spoken about just a few slides ago. So there needs to have been either, firstly, 2 or more unprovoked seizures separated by more than 24 hours. Secondly, 1 unprovoked seizure with a greater than or equal to 60% chance of having another unprovoked seizure in the next 10 years based on having either abnormal imaging, usually an MRI, otherwise a CT, which is thought to be epileptogenic, or having an abnormally epileptogenic interictal EEG, or ictal EEG, although that's unlikely. And the third way that you can meet the diagnosis is by having 1 unprovoked seizure, but also meeting the diagnosis for a specific epilepsy syndrome, which realistically is going to be based on the imaging and the EEG anyway, and or on a family history with supportive genetic testing. The fourth thing that you need to do is then determine what type of epilepsy the patient has. So you've determined that the patient has epilepsy, but what type of epilepsy do they have? Generally speaking, the type of epilepsy matches the type of seizures that they have, but there can be overlap, and we'll talk about that very shortly. The fifth thing you need to do is try your best to determine the underlying epilepsy syndrome if possible. This is not always possible, and in fact, about 50% of the time, it's not possible even after our best attempts to identify the type of epilepsy syndrome, but you need to try. And then the last thing you need to do, and you kind of do this in parallel with the preceding 5 steps, is to try and determine the underlying etiology of the epilepsy and the epilepsy syndrome if possible. So, how do the type of seizures match the type of epilepsy and the type of epilepsy syndrome? So I've developed a diagram or a flow chart here, which I've adapted from the ILAE, the International League Against Epilepsy. So at the top, you've got the type of seizure. So you've got your focal or focal onset seizures, your generalized or generalized onset seizures, and your unknown onset seizures. Then if, say, a patient is having 2, 3, 4 unprovoked recurrent seizures in any of those categories, then the patient's going to have either a focal onset epilepsy, a generalized onset epilepsy, or an unknown onset epilepsy, respectively. However, the overlap is that you can also have an epilepsy which is a mixed epilepsy. So if a patient is having both focal onset seizures and generalized onset seizures, then they would be considered to have a mixed epilepsy consisting of both focal and generalized onset seizures. Then in terms of the type of epilepsy syndrome, there are these various epilepsy syndromes that I'm going to talk about shortly, and they can also be thought of in terms of whether they consist of focal onset seizures, generalized onset seizures, unknown onset seizures, or a mix. And then finally, you need to think about what's the etiology of the underlying epilepsy syndrome. So some epilepsy syndromes strongly imply a particular underlying etiology or another, but some don't. So some epilepsy syndromes really are just that, they're syndromes, and there can be a number of different causes. And so you still need to try and get to the bottom of what the underlying cause is. And as I mentioned previously, you have to think about the etiology as you're going through this process. So what are some etiologies? Well, think genetic, think hypoxic ischemic, structural, which can be either vascular or non-vascular malformations, masses, metabolic causes, inflammatory, infective, neoplastic, paraneoplastic causes, etc. Sometimes you're successful in determining the epilepsy syndrome and the etiology. Sometimes you're not successful, but you have to try. So, what are these epilepsy syndromes? Well, they're defined differently according to the age of onset of the seizures and the epilepsy. And the ILAE in 2022 most recently redefined these, and they grouped them into three main groups. The first group is neonatal and infantile onset. The second is childhood onset. And the third is variable age of onset, which pragmatically includes both juvenile onset and adult onset epilepsies, and also some other epilepsies that can manifest at many different ages. Essentially, an epilepsy syndrome is defined by a combination of three things. The number 3 is coming up a lot in this talk. So firstly, the seizure types and the patterns of seizures, and the times of the day that the seizures happen, the triggers of the seizures, all of these are relevant. Secondly, what are the ictal and the interictal EEG patterns? And thirdly, what, if any, comorbidities does the patient have? And that's especially important in the context of pediatric epilepsy syndromes and whether there are any associated cognitive or developmental impairment present. And often, depending on the degree of comorbidity present, it distinguishes the relatively speaking less severe or previously called benign epilepsy syndromes from some of the more severe nasty epilepsy syndromes that often have associated intellectual disability, cognitive delay, lots of other neurodevelopmental and sometimes non-neurological, so systemic, maybe cardiac, maybe hepatic, renal involvement. And they often fall into this group called the DEEs, so the Developmental and/or Epileptic Encephalopathies, and we'll talk about that shortly. So what I'd like to do in the remainder of this episode is give you all an overview of what all the epilepsy syndromes actually are. So basically what their names are, so that you know what they are and so that you know what to look out for. And when you come across these names, you're not hearing about them for the first time and you're familiar with them. I'm not going to have time to go into the details of the clinical presentation, the ictal and interictal EEG patterns and the comorbidities for every single one of those in this episode, because otherwise the episode would go for 2 or 3 hours. So what I'll do is in 3 future episodes, I'll go into detail on the clinical, electrographic and comorbid features of neonatal and infantile epilepsies, and then childhood epilepsies, and then juvenile and adult and variable age epilepsies. But right now we're doing an overview. So let's start chronologically. Let's begin with the neonates and infants. So I've just copied this figure straight from the ILAE 2022 actually, but let's read through it. And it's important to recognize that the ILAE has changed all the names recently. There's reasons that they've done that. I've already said it's to try and de-emphasize the benign component of some of the less severe forms of these epilepsies because we know they're not completely benign. Most of the eponymous names have been removed, not all of them, but most of them, to give more descriptive names of what the epilepsy syndrome actually consists of. And they've all ended up with somewhat catchy acronyms. However, I do think as a non-pediatric neurologist and epileptologist, some of these acronyms are quite similar to each other and they're a bit hard to remember and keep track of, especially when they keep changing the names all the time. But that's just what we have to work with, so let's go through them. So there are 3 main groups again. The first group are the self-limited epilepsies. So these were formerly the more benign forms of epilepsies. So there are 5 in this group. So you've got self-limited neonatal epilepsy, or SELNE. You've got your self-limited familial neonatal infantile epilepsy, or SELFNIE. Then there's self-limited infantile epilepsy, SELIE, Sealy. Then there's genetic epilepsy with febrile seizures plus, or GEFS GEFS+, and then there's myoclonic epilepsy in infancy, MEI. Next are the more severe forms of neonatal and infantile epilepsy, and these are the DEEs, the developmental and epileptic encephalopathies. And before I list them, I'd just like to explain what this term means, because it's a bit confusing, and it did confuse me when I first came across it. And there is a distinction between a DEE and an EE, and some people call them developmental and or epileptic encephalopathies. So what it means is, firstly, they've all got the second E in them, so they've all got the encephalopathy component, okay? So there's a patient who's having seizures and some degree of cognitive or neurodevelopmental problems. But the question then is, what's the cause of the encephalopathy? So is it the epilepsy itself which is causing the encephalopathy? Is it the recurrent seizures which are causing the encephalopathy? Or is it the underlying root problem which is causing the seizures and is also independently causing the encephalopathy? And that's what it boils down to. So, for instance, you might have a patient who has tuberous sclerosis and associated Lennox-Gastaut Syndrome, and that would be a DEE, a developmental and epileptic encephalopathy that actually comes on in children, not in neonates and infants. And that would be a DEE because the underlying tuberous sclerosis can also cause the encephalopathy independent of the tuberous sclerosis causing the seizures, which also cause the encephalopathy. So you've got a double whammy there. The encephalopathy is actually being caused by the underlying problem as well as by the seizures, which are also being caused by the underlying problem. Conversely, an epileptic encephalopathy is an encephalopathy where the epileptic seizures are causing the encephalopathy, but the underlying root problem is not thought to be the cause of the encephalopathy. In practice, they're often considered together in a group, and that's why they're known as the DEEs. So I hope that's cleared up any potential confusion there. So in the neonatal and infantile period, the 4 DEEs are early infantile, developmental, and epileptic encephalopathy, or EIDE, EIDEE. Secondly, there's epilepsy in infancy with migrating focal seizures, EIMFS. Thirdly, there's infantile epileptic spasms syndrome, EISS, and that's what was formerly known as West syndrome, which many of you may have heard of before and may be familiar with. And lastly, there's one eponym which has remained, which is Dravet syndrome, spelled DRAVET, and the acronym for that is just DS. Then the third group, the ILAE, has characterized as being etiology-specific syndromes. So I said before that some of the epilepsy syndromes don't imply a specific etiology, and a great example of that would be Lennox-Gastaut syndrome. There are many different potential etiological causes of Lennox-Gastaut syndrome. Conversely, there are some epilepsy syndromes that essentially do lock you into a specific etiology, and these etiology-specific syndromes are a perfect example of that. So I'll read off the ones that are listed here. So there's KCN Q2 DEE, pyridoxine-dependent DEE, pyridoxamine 5-phosphate deficiency DEE, CDKL5 DEE, PCDH19 clustering epilepsy, GLUT1, so that's glucose transporter 1 deficiency syndrome related epilepsy, Sturge-Weber syndrome, which is one of the classic neurovascular cutaneous syndromes associated with port wine stains, cutaneous vascular malformations, and intracranial vascular malformations that can be a cause of epilepsy. And lastly, and an interesting one, gelastic seizures with hypothalamic hamartoma. So that's something that you'll probably only come across in an epilepsy rotation or maybe in a particularly difficult examination, but a gelastic seizure is a seizure that manifests with laughter, and that really does suggest that the patient may have specifically a hypothalamic hamartoma. It's not pathognomonic. There can be gelastic seizures caused by other problems, and you can have hypothalamic hamartomas that don't cause gelastic seizures, but the two are very, very closely linked. So you really need to think of a hypothalamic hamartoma if you see a patient with gelastic seizures. And I've always found that quite interesting because we always think of epilepsy as being predominantly a cortical problem, especially a cerebral cortical problem. But this is an example where we have a structural problem not in the cortex, it's in the hypothalamus, and that's causing the epilepsy in this instance. And this is beyond the scope of the presentation, but you can actually very rarely also have cerebellar epilepsies. There have been pretty convincing case reports and case series on that as well. But the takeaway message in regards to that is that for all intents and purposes, almost always, epilepsy is from a problem with the cerebral cortex, and these really are very rare, exceptional exceptions to that rule. So we've dealt with the neonates and the infants now, so let's move on to the childhood period. So these again are grouped up into 3 different groups. The first group is the focal epilepsies in children, and that group has a name, selfies, self-limited focal epilepsies. So the first of these I already mentioned earlier, selects self-limited focal epilepsy of childhood, which was formerly known as benign Rolandic epilepsy, and it was also formerly known as benign epilepsy with centrotemporal spikes. And as the name implies, on an EEG interictally and then also ictally, you see epileptiform discharges in the centrotemporal regions, so C3, C4, T3, T4, for instance, but they're focal. But they should be bilateral and bilaterally independent. So you get these focal epileptiform discharges, but they're in the centrotemporal region on the left side of the brain sometimes, and then on the right side of the brain sometimes. Whereas if you see someone who's always having discharges exclusively on one side of the brain and not the other side of the brain, that's a bit of a red flag, and you might consider whether actually there's a structural lesion there and it's not just garden variety selects, and it might be something else. The name's quite nice in that it actually tells you what the underlying EEG change is. So if you ever forget, just think, well, what does the CTS stand for in selects? And it tells you what the EEG change is. The next one is SELAS, SELEAS, which is self-limited epilepsy with autonomic seizures. And this was formerly known as Panayiotis syndrome. And then the next two are interesting. So you've got COVE and POLE. COVE, COVE, stands for Childhood Occipital Visual Epilepsy, which was formerly known as Late Onset Benign Occipital Epilepsy, Gastaut Syndrome, or Idiopathic Childhood Epilepsy of the Gastaut type, whereas POLE, POLE, is Photosensitive Occipital Lobe Epilepsy. Then you've got your Genetic Generalised Epilepsies, or GGEs, that manifest in childhood. That's the second category. And there are 3 here. So the first is Childhood Absence Epilepsy, CAE, which of course is one of the 4 IGEs, or Idiopathic Generalised Epilepsies. Secondly, there's Epilepsy with Eyelid Myoclonia, EEM, which was formerly known as Juveniles syndrome, or some people say Jevons syndrome. I'm never sure which of the 2 it is. And the third one is epilepsy with myoclonic absences. And then the third group manifesting in childhood, again, is developmental and epileptic encephalopathies, DEEs, or EEs, epileptic encephalopathies, with their onset in childhood. And this time there are 5 that manifest in childhood. The first is known as EMATS, EMATS, or epilepsy with myoclonic atonic seizures. And this was formerly known as Dozer syndrome. And I learnt that pronunciation from one of my German epileptology colleagues who was getting frustrated that everyone calls it Deuce syndrome in Australia, but I'm told that it's Dozer syndrome. You might have heard of the term an astatic seizure. That's really essentially synonymous with an atonic seizure, and you might have heard of myotonic astatic seizures and Dozer syndrome in the context of that, and all of those words are referring to the same syndrome. Secondly, there's Lennox-Gastaut Syndrome, which I've mentioned a few times in this epilepsy podcast so far. And I did say that I wasn't going to go into the electrographic components of the syndromes, but I'm going to make an exception here briefly because this is really important. So Lennox-Gastaut syndrome has two classic electrographic features which are good to know about. The first one is slow generalized spike and wave. So what does that mean? So generalized, strictly speaking, it means it's affecting both cerebral hemispheres in anatomically homologous areas, so bifrontal or bitemporal or bioccipital. But more loosely speaking, it basically means that it's affecting the whole brain at the same time. So there are synchronous discharges throughout the whole brain on the left and the right, anterior through posterior. That's what the generalized means, and there may be an anterior predominance or a posterior predominance, but they're still synchronous and seen everywhere. Spike and wave refers to the morphology of the discharge. So I've been using this terminology a bit, but I should probably define it. So a spike, by definition, is a brief discharge on an EEG that lasts for less than or equal to 70 milliseconds. And that's an important thing to know. And one thing that confused me a little bit was the 70 is measured from the deflection from the baseline until it gets back to the baseline. So it's not just half of it, it's the whole thing. So you get this little sharp spike, and a different EEG teacher that I've had previously described it as it's so sharp you could poke your finger on it. So if you're looking at an EEG tracing on a computer monitor and it looks like a little pin that you could poke your finger on it, then it's probably a spike. And then the wave refers really to a slow wave that follows after the spike. And there needs to not be a gap in between the spike and the slow wave. It needs to be a spike immediately followed by a slow wave. And then what does the slow refer to? So that refers to the frequency of the generalized spike and wave discharges within a burst of discharges. So it's the intra-burst frequency, not the inter-burst frequency. It's the intra-burst frequency. And slow is obviously a relative term, and it implies that there's a normal and a fast. So when we say normal, that's referring to your classic 3 Hertz generalized spike and wave that you see in classic typical absence seizures, such as you would see in a patient with childhood or juvenile absence epilepsy, or someone with a otherwise undefined idiopathic generalized epilepsy with generalized tonic-clonic seizures and absence seizures. And Hertz, of course, means just the number of times per second. It's basically the frames per second. If you're thinking about the TV or a computer monitor, frames per second is the same thing as Hertz. So 3 Hertz means that there are 3 discharges every second. So there's 0.333 milliseconds in between each of the discharges. So that's normal. So slow is slower than that. So by definition, it's less than 2.5 Hertz is slow. And then fast, I already referred to in the context of JME, juvenile myoclonic epilepsy. And there you're looking at 4, 5, 6 Hertz would be considered fast generalized spike and wave discharges. The second thing, which is characteristic and in fact required for the diagnosis of Lennox-Gastaut syndrome, is this GPFA, which is generalized paroxysmal fast activity. So let's break that down. Generalized, again, we've spoken about that. Strictly speaking, it refers to bilaterally synchronous discharges in a homologous brain region anatomically, so bifrontal, bitemporal, bioccipital, but more loosely speaking, it really means affecting the whole brain at once. Paroxysmal just means that it's happening in bursts and then it stops happening and then it starts happening again. So it's not something which is just present constantly for 20 minutes. You see it, it's there, and then it's gone, and then it comes back again. So it comes and goes in paroxysms. Fast just means it's fast. And what that really means in this context is we're looking at 15, 20, 25, 30 Hertz perhaps. Probably should have looked that up before I started making this talk, but it means that it's fast activity. So basically in the beta band, perhaps fast alpha to beta band discharges. I won't go into the bands in this episode. That's probably overdoing it for this episode, but we'll talk about that next time. And activity is just a descriptor to say that something's happening at the time. So in reality, it's probably good to recognize that on an EEG, when a discharge is fast in terms of the frequency of a rhythm, typically the amplitude or the voltage of the discharge reduces, so it looks less tall. So generally speaking, the faster that something is, so the narrower that it appears on the computer monitor or on the piece of paper, the shorter it is as well. So what that means is, in the context of generalized paroxysmal fast activity, it's almost always low voltage. So you see these little caterpillars on the EEG, and if you zoom in, it would be like seeing this really little caterpillar sitting there on the page. And that's in contrast to slow rhythms, such as, say, someone had a stroke and they had some left frontal region slowing, and they might have polymorphic high amplitude delta slowing at 2 Hz. Typically, as I just gave it away, that's high amplitude. So typically the slower a discharge is, the bigger it is. So when we're talking about generalized paroxysmal fast activity, you're looking for this low voltage, low amplitude, high frequency, caterpillar looking discharge on the page. It can be difficult to distinguish GPFA sometimes from EMG, electromyography artifact. That can be really quite challenging at times. And a previous EEG tutor of mine taught me that one way you can try and do that is GPFA or beta rhythms. If you really try, you can still count them. So even though it's fast, it's not so fast that you can't count them. You can still kind of make out the individual waves within the discharge. Whereas EMG is just so fast, maybe it's at 60 or 70 Hertz, that even if you try, you can't count it. It literally looks vertical. Of course, it's not truly vertical. If you expanded the time base to the entire computer monitor per second, so maybe that would be 20 centimeters per single second, even at 60 Hertz, even with EMG, you would still be able to count it. But at normal display resolutions, at normal paper speeds, so at say 30 millimeters per second, it's not countable. So the other thing I'd like to say about Lennox-Gastaut syndrome, which is something that I didn't realize even as a student or a junior doctor or a basic physician trainee, which is our equivalent of kind of our examinations in Australia before we subspecialize into neurology training, and I only learned 6 months into my specialized neurology training, is that Lennox-Gastaut syndrome, whilst it is a diagnosis, it's also kind of not a diagnosis. What do I mean by that? I mean, you can get more specific. It's similar to anemia or iron deficiency anemia. Hematologists have always taught me that, Tom, anemia is not a diagnosis. Anemia is a syndrome, or it's getting close to a diagnosis, but it's not really a diagnosis. I need to know, is it microcytic, macrocytic, hyperchromic? Is it iron deficiency? Is it in the context of B12 or folate deficiency? Is it in the context of alcohol? Do they have marrow aplasia? Do they have thalassemia? Do they have a hematological malignancy? Or has the patient just got blood loss? Have they got a gastrointestinal tumor as a cause for occult GI bleeding? So what they would say is that making a diagnosis of anemia isn't good enough. It's not really a diagnosis. You need to go further, you need to go deeper, and you need to get to the true root cause, and that's the real diagnosis. Lennox-Gastaut syndrome is kind of the same in that there's lots of different etiological causes for Lennox-Gastaut syndrome, and it is helpful if you can go deeper and get to the underlying cause, because there may be changes to your treatment that you can direct according to the cause. That being said, sometimes you try and you just can't get there, and sometimes even if you do get there, it might not change the treatment. So the parallel that I drew with anemia just now isn't a perfect parallel, but hopefully I've made my point. So I already gave an example before of tuberous sclerosis being a potential cause for Lennox-Gastaut syndrome, or there could be a number of genetic mutations, or perhaps someone had cerebral palsy and a nasty hypoxic ischemic encephalopathy, which is related to their Lennox-Gastaut syndrome. So they're the things to think about, and you need to investigate for them with imaging and genetic testing in most instances. Now let's move on because I got a bit sidetracked there. So just to regroup us, we're talking about the DEEs with their onset in childhood. We've spoken about Dozer syndrome and about Lennox-Gastaut syndrome. The next one is DEE SWAS and EE-SWAS, and that stands for spike wave activation in sleep. And interestingly, these patients, their EEGs look okay during the day, relatively speaking, but then they go to sleep and then they have these really, really intense, frequent epileptiform discharges in sleep to the extent that it kind of looks like non-convulsive status epilepticus when they're asleep. The fifth one is febrile infection-related epilepsy syndrome, FIRES, which importantly is a cause of NORS, which is new onset refractory status epilepticus. And these are really, really nasty acute epilepsy syndromes where you have this febrile illness and then you get this explosive onset of treatment refractory status epilepticus, sometimes super refractory status epilepticus, requiring ICU admission, infusions of midazolam, propofol, phenobarbital, lots of other anti-seizure medications, lumbar punctures, imaging, really trying to get to the bottom of it. And that's a nasty epilepsy syndrome. The last one is hemiconvulsion hemiplegia epilepsy syndrome, or HHE. And as the name implies, that's a patient who has hemiconvulsions in the context of hemiplegia. So now let's move on to the last group in terms of age of onset, which is the variable age of onset group. And this includes juveniles and adults, along with some other epilepsy syndromes that can come on at any time. There is a little bit of overlap here, and I'll come to that when we get to the overlap. So again, I've just copied this diagram straight from the ILAE 2022. And I should say that all these papers were actually published in Epilepsia, which is the big epilepsy journal, which is the journal of the ILAE. But the links to them all can be found from the ILAE website, and they're worth a read if you have the time. So firstly, in your variable age of onset cohort, you have your generalized epilepsy syndromes, and they are your IGEs, your idiopathic generalized epilepsies. And they include 3 in this age group and then a 4th one, which we already talked about. So the 3 in this cohort are juvenile myoclonic epilepsy, JME, juvenile absence epilepsy, JAE, and epilepsy with generalized tonic-clonic seizures alone, GTCA. So that last group is an interesting one. So if you see a patient in clinic who might be an adult, for instance, or a juvenile patient, and they're having generalized tonic-clonic seizures, which are unprovoked and recurrent, more than 24 hours apart, but they've never had any other type of generalized seizure or focal seizure, you will likely diagnose them with an IGE, but you may be able to more specifically diagnose them with the syndrome of epilepsy with generalized tonic-clonic seizures alone. The 4th IGE, which is actually in children, is the childhood absence epilepsy, which we spoke about a few slides ago. So the next group in this cohort are the focal epilepsy syndromes. These are either self-limited or familial mesial temporal lobe epilepsy, FMTLE, or epilepsy with auditory features, EAF. And the self-limited ones are subdivided into 2 types we've already spoken about. So that's childhood occipital visual epilepsy, COVE, and photosensitive occipital lobe epilepsy, POL. The reason they've doubled up here is because even though they're usually childhood onset, that's not always the case. So they're covering their bases and doubling them up here. Next, they have the group of epilepsy syndromes with developmental and/or epileptic encephalopathy, or with progressive neurological deterioration. And here, again, there's a bit of overlap. They've got FIRES, febrile infection-related epilepsy syndrome. So again, that's usually in children, but not always. So you can get patients who are younger or older than children who can also have FIRES. And then there's also Rasmussen syndrome. So that's a really interesting one and good to know something about. So Rasmussen syndrome, you get this hemicerebral involvement, so the whole left hemisphere or big parts of the left hemisphere or the right hemisphere are involved. The etiology is a bit debated. It's thought most likely to be an autoimmune process, although some people have argued that there's an underlying infective cause, or perhaps it's a molecular mimicry with an infective trigger then kicking off an autoimmune process. And you see atrophy on the MRI, which progresses eventually into a hemiatrophy sometimes. And on the EEG, you may initially see interictal or ictal epileptiform discharges, always in the same hemisphere, but it may be in one part of the hemisphere at one time and then on the same recording, or on another recording months or years down the track, it may be in a different area and vice versa. And if you get to them early enough, so if these patients manifest early on, sometimes you can treat this with some surgical interventions such as a functional hemispherectomy, where you disconnect the two hemispheres so that the hemisphere which is dysfunctioning is effectively separated from the rest of the brain and the rest of the body, and it doesn't do anything. But they use the word functional because it's not actually a hemispherectomy anatomically, because the hemisphere is still left inside the cranium. It's just disconnected or deafferented from the rest of the brain. And I understand, although not being a neurosurgeon or a pediatrician, that they do sometimes do anatomic hemispherectomies as well, where they actually do remove the hemisphere. The reason this is mainly feasible when you get the patient early enough is because of neuroplasticity. So you can do, if it's really required, these major neurosurgical interventions if you get to the patient before their brain areas have organized to a particular hemisphere in a particular location, and it's made its decision and it's stuck there and it's not going anywhere. And that's why it's also interesting when a patient's left-handed, or it's really why we ask about handedness at all, is sometimes if a patient is left-handed, for instance, it might be that they were originally going to be right-handed, so maybe their handedness dominance was going to be in the left hemisphere initially, but there was some early in life insult to the left hemisphere, and it was early enough in life, maybe before the age of 2 or 3 or so, and so the brain was plastic enough to say, well, I'm not going to have my hand dominance in my left hemisphere because that's not doing it for me. So the hand dominance is going to jump across to the right hemisphere instead and develop in the right hemisphere. And so the patient's then left-handed. And the same can be true of language areas. So it may be that the patient was going to have their language dominance be in the left hemisphere, but if there was an early in life insult before the age of, say, 2 or 3 years, give or take, and it can vary, and actually it can go a bit higher than that. It can go to 5 or 6 years, even in some instances, for some of this handedness and language, but the earlier the better, and that's an important point to make. It may be that they were going to be language dominant in their left hemisphere, but because of an insult, it then jumped across to the right hemisphere instead. And so sometimes we actually do a functional MRI to determine where the language areas are. And we do that often in our pre-surgical epilepsy evaluations if we're thinking about doing, say, a resection somewhere near where the language areas might be. We want to know which side the language areas are on and whether the planned surgery is going to impact on those areas or not, to determine whether the surgery is even possible, and to determine what type of surgery to do and the anatomical margins of the surgery. And interestingly, I've seen at least one case recently where there was bilateral language organization. So we hypothesized in that case that the insult must have occurred around the time of point of no return, and the language centers kind of half jumped over to the other side, but they didn't quite all make it across. And so there was bilateral organization of language dominance in this patient. That's speculation as to is that really what happened or not. It's hard to know. Probably we'll never know, but it's a pretty plausible hypothesis, and it probably is what happened in that case. They can also try and distinguish Broca's area from Wernicke's area based on the type of tasks that they do during the fMRI, so they can get this patient to talk and see what part of the brain lights up, and that would be indicative of Broca's area, which is typically in the inferior frontal gyrus, typically in the left hemisphere. And conversely, to assess Wernicke's area, which is as opposed to expressive language, which is Broca's area, Wernicke's is receptive language. That's typically in the superior temporal gyrus, and that's typically in the left hemisphere. And so to test that on an fMRI, what they do is they would activate that by talking to the patient or saying words and asking the patient to comprehend those words. So it's really interesting. And the reason that I'm telling you these things, I know that I'm getting off topic, but the reason I'm telling you these things is to try and create connections so that you can think about, oh, this is what fMRI does. This is what we do in a pre-surgical epilepsy evaluation. That's what some of these epilepsy syndromes are relevant to. That's why it matters what the age of onset is. That's what Rasmussen syndrome is. So hopefully I'm drawing some connections in your minds. Then finally, in the DEEs, or progressive neurological deterioration of variable age of onset, there are the progressive myoclonic epilepsies. And that's why the progressive neurological deterioration part is put in here. So with some of these epilepsy syndromes, it's not just developmental domains which are affected early in life. You can get these progressive neurologic deterioration with time, not just in the childhood period or the infantile period, in the context of these underlying problems and these associated epilepsy syndromes. So in some of the progressive myoclonic epilepsies, you can develop progressive weakness in the part of the body where the myoclonus is, for example. Then there are some examples of overlap. So in terms of the focal epilepsy syndromes, but they also, despite being these focal epilepsy syndromes, they also have developmental and epileptic encephalopathies or progressive neurologic deterioration to some extent on a spectrum. And so there's three here. So there's mesial temporal lobe epilepsy with hippocampal sclerosis. There's sleep-related hypermotor or hyperkinetic epilepsy, SHE. And there's focal familial epilepsy with variable foci. And then lastly, there are combined generalized and focal epilepsy syndromes. And the example that's given here is epilepsy with reading-induced seizures. And you may recall, if you saw one of the previous episodes on seizure definitions and seizure classifications, reading-induced seizures are an example of a reflex epilepsy. So reading triggers seizures in a patient, whereas of course reading doesn't trigger seizures in most patients. So it's not a typical provoking factor, but it's a reflex epilepsy. So this phrase, the GGEs, the Genetic Generalised Epilepsies, is kind of an umbrella term which encompasses all of the IGEs and some of the DEEs. So why is that important? So the IGEs, they're all genetic, whereas the DEEs, some of them are genetic, but some of them are not genetic. So it might have just been a hypoxic ischemic encephalopathy that was sustained antenatally or perinatally or postnatally. That's not a genetic problem, but it can be a cause of a DEE. It could be a cause of Lennox-Gastaut Syndrome, for instance. So this is the last slide of the presentation with content on it. So it really begs the question, why does determining this specific epilepsy type and syndrome and etiology actually matter? Why am I going to all this effort? Why am I putting the patient through all these clinic visits, all these investigations? Well, it matters a lot. Firstly, and most obviously, it changes the treatment that we use. We use really quite different anti-seizure medications for focal epilepsies as opposed to generalized epilepsies. That being said, there are quite a number of anti-seizure medications that are broad spectrum and they address both of them. So it's like addressing two birds with one stone. But there are quite a lot of anti-seizure medications that are not like that and are really only appropriate for one or the other. So a good example would be carbamazepine is a very potent and effective anti-seizure medication for focal epilepsies, but it's not good for generalized epilepsies most of the time. Whereas conversely, valproate, despite being a potent and broad spectrum anti-seizure medication, really its best use is for generalized epilepsy syndromes where it's a very potent, one of the most potent anti-seizure medications for generalized epilepsy syndromes, but it's probably not as effective for focal epilepsy syndromes, and there's lots of better alternatives most of the time for focal epilepsy syndromes. Another example for generalized epilepsy syndromes would be ethosuximide, which is highly specific for absence seizures, but it does nothing for generalized tonic-clonic seizures or other forms of generalized seizures, but it's very good specifically for absence seizures, which are, of course, a form of generalized seizure. Secondly, we sometimes use different antiseizure medications for specific epilepsy syndromes. So, for example, cannabidiol, CBD, or fenfluramine are used for Lennox-Gastaut syndrome and Dravet syndrome and other DEEs, but they're not really used for other forms of epilepsies apart from those specific epilepsy syndromes. And similarly, vigabatrin and glucocorticoids or corticosteroids are often used for West syndrome, whereas they're not typically used in many other epilepsy syndromes. And of course, this has quite significant financial ramifications in many places. I can't speak to the whole world, but I can say that in Australia, government funding through our version of the government paying for medications, which we call our PBS, our Pharmaceutical Benefit Scheme, is contingent on the diagnosis in order to access the medications being paid for by the government. Otherwise, the patient has to foot the bill themselves, and the out-of-pocket costs are often just completely exorbitant, and so they're not realistically accessible or usable in that context. The other side of the coin is also true. So we use some antiseizure medications for some epilepsy syndromes, and conversely, we avoid other antiseizure medications for some other epilepsy syndromes. So, for instance, we avoid sodium channel blockers in Dravet syndrome, and we avoid most sodium channel blockers in juvenile myoclonic epilepsy and in other myoclonic epilepsy syndromes. Although I will point out that one of my epilepsy colleagues makes the good point that referring to antiseizure medications as sodium channel blockers is probably oversimplifying things a little bit too much. They certainly can be considered as a class, and there are class effects, and it is like beta blockers having class effects or ACE inhibitors having class effects. But as we know, there are individual drug-specific factors as well. Not all beta blockers are the same. For instance, metoprolol might be a good choice for someone with atrial fibrillation with rapid ventricular rate, whereas bisoprolol might be a better choice for someone who has associated heart failure with reduced ejection fraction, formerly known as systolic heart failure. And nebivolol might be a better beta blocker for an elderly, for a geriatric patient. So similar to that, there are individual differences between the sodium channel blockers as well. And often the sodium channel blockers may have quite significant differences in terms of other aspects of their mechanism of action, their pharmacodynamics, their pharmacokinetics, and the differences between sodium channel blockers are probably bigger than the differences between medications in other drug classes overall. So the reason I told you that is there are some exceptions to the rule in terms of not using sodium channel blockers in myoclonic epilepsies. One good example is lamotrigine. So, of course, lamotrigine is a sodium channel blocker, but it's actually commonly used in juvenile myoclonic epilepsy. And almost all of the time, carbamazepine is a complete no-go in myoclonic epilepsies, but I have heard anecdotal reports from colleagues more than once of cases of myoclonic epilepsies which, against all odds, seem to have actually responded to carbamazepine. So maybe someone else started some carbamazepine when they didn't really know that they shouldn't, or maybe the epilepsy was initially thought to be a focal epilepsy and then it transpired that actually it was a generalized epilepsy and they were already on carbamazepine. So I hope I'm not confusing you here, and I'm not saying to treat your patients with myoclonic epilepsies with carbamazepine, because that's absolutely what you should not do. The takeaway message is most of the time do not use sodium channel blockers and certainly do not use carbamazepine in Dravet syndrome or in juvenile myoclonic epilepsy or other myoclonic epilepsies. But you do need to think a little bit more openly about it, and in particular, lamotrigine does have a role in the treatment of juvenile myoclonic epilepsy. Now, in what other ways is it important to get to the bottom of the epilepsy syndrome and the etiology? So sometimes we use different anti-seizure medications or therapeutic approaches for specific etiologies. So ketogenic diets, for instance, may work well for some genetic metabolic-based epilepsies, and they can be used in other epilepsies as well. But conversely, they may be completely contraindicated depending on what the genetic metabolic-based problem is. It may be that making dietary changes in order to induce a ketogenic state may actually not be safe and may cause significant morbidity or even mortality in someone whose metabolic problem means that they just can't process ketones and they actually need carbohydrates, they need glucose in order to fuel their brain and the other cells in their body. Another example, and quite a good example, would be the use of mTOR inhibitors. So that's everolimus and sirolimus for tuberous sclerosis complex-related epilepsies, in particular Lennox-Gastaut syndrome. And also we may use immunosuppression or antimicrobials or antineoplastics if the epilepsy is immune-based or infective-based or neoplastic-based, respectively. Also, knowing the epilepsy syndrome and the etiology informs the prognosis, and it then allows us to set realistic treatment targets. Namely, are we shooting for seizure freedom or are we aiming just for seizure control? So for a patient who has mesial temporal lobe epilepsy in the context of hippocampal sclerosis, we're aiming most of the time for seizure freedom. And they may have drug-resistant epilepsy, in which case we still want seizure freedom, so they would be a good candidate to be reviewed in a comprehensive epilepsy center for evaluation of epilepsy surgery. Conversely, if the patient has a DEE, if they have Lennox-Gastaut syndrome or Dravet syndrome, it's almost unheard of that that patient would be seizure-free. It's basically not achievable, but really the aim is going to be reducing the frequency and the burden of seizures, but at the same time, balancing that against the side effects, the cumulative side effects from having multiple anti-seizure medications on board. And I've seen the balance go too far in either direction. I've got a patient at the moment who I'm treating actually, who I just inherited from another colleague who I think has been undertreated. They've got a DEE, which is probably Lennox-Gastaut syndrome, and they really seem to be undertreated. They were only on one anti-seizure medication when I saw them, and they were having really frequent seizures, and they clearly require an escalation of their anti-seizure medication to try and control their seizure frequency better. I've also seen the other side of the coin where a patient with Lennox-Gastaut syndrome is literally on 7 different anti-seizure medications at high doses, and the patient might be just completely bombed out by the anti-seizure medications, just completely zombified, sedated, not able to do anything. They're just so symptomatic from their medications. And sometimes you get diminishing returns by having 6, 7, 8 medications on board, and some of the medications might not have even really done anything in terms of controlling the seizures. So it's really trying to get that balance, not too little, not too much, not too hot, not too cold, just right, to use who was that? That was the bears and the porridge, wasn't it? The 3 little bears analogy. And you can apply the 3 little bears analogy to the treatment of DEEs. You need enough anti-seizure medications on board to try and control the seizures. You're not going to make them seizure-free, but to control the seizures as best you can, but not having so many treatments on board that the benefit of the anti-seizure medications is starting to be outweighed by all of their side effects. Why else is defining the epilepsy syndrome and etiology important? Well, in terms of prognostication, it helps with some non-pharmacological strategies as well. It helps with families planning schooling arrangements. Does my child need to go to mainstream schooling, or do they need parallel stream schooling arrangements? Living arrangements. Is my child going to be able to live independently or not? Will they need supported independent living? One thing that comes up a bit as well is, how's my child going to go when I'm old as the parent, and when I die, what's my child going to do when they don't have me to care from them? It's heartbreaking, but it's a real consideration that you need to take into account. And it also really helps with accessing public funding to allied health. So I can't speak for other countries, but I imagine it's similar. But in Australia, we have the NDIS, the National Disability Insurance Scheme, and you require one of these diagnoses in some instances to unlock higher tiers of government-funded support to help pay the bill for physiotherapists, occupational therapists, carers, group homes, etc. And lastly, it can also help with genetic counseling for other family members. So family might want to know, well, does my child or my sibling who has this nasty epilepsy syndrome, is it genetic? Am I at risk of passing the same syndrome onto my offspring? What's the risk? Is it such that in vitro fertilization might be an option to try and mitigate that risk? So they're all complex questions which may be answered by being able to make a diagnosis at the syndromic and etiological level for the epilepsies. So there was a lot of content that I just went through, but that's the end of today's episode. Thank you so much for tuning in. The next episode will be on distinguishing seizures from seizure mimics. And this is a really, really important episode, not just for neurologists and for trainees, but for emergency physicians, general practitioners, and really anyone who is working in the undifferentiated environment where they're seeing walk-in patients. So don't forget to like, comment, and subscribe. Visit our website at rneurologyeducation.org. That's R with the letter R, to access all of our media formats and additional content in one place. You can find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and also join us on your preferred social media platforms. You can find us at R Neurology Education, with the exception of X, which is at R Neuroeducation. And please email us on contact@rneurologyeducation.org to subscribe for updates or with any questions or queries that you may have. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.